Baik. Dia risau.
Salam sejahtera and good morning to Yang Berusaha Datuk Dr. Muhammad Razif bin Abu Hassan, Deputy Director of Health, Research and Technical Support, Ministry of Health Malaysia, the Honourable Speaker of the Day, Dr. Luis Pizarro, Executive Director of DNDi, Yang Berusaha Dr. Haji Tahir bin Aris, Director of Institute for Medical Research, distinguished guests from DNDi, Head of Centres and Head of Units at the National Institutes of Health Malaysia, NIH, and all who are present here today. We welcome you to the DNDi 20th Anniversary Program with the theme, Empowering Endemic Countries in Delivering the Best Science for the Most Affected. Please note that the event is being live streamed via YouTube NIH Malaysia channel. For online viewers, kindly adjust your video settings to the highest resolution for the best visual quality. Without further ado, we now would like to welcome Datuk Dr. Muhammad Razif for his opening remark.
So it's not here. Bismillahirrahmanirrahim. Ketua-ketua pusat, ketua-ketua unit dan tidak lupa juga kepada seluruh warga NIH yang terkasih sekalian. A very good morning and welcome to DNDi's 20th Anniversary Special Talk in Southeast Asia by Dr. Luis Pizarro. Empowering endemic countries in delivering the best science for most neglected. Held at NIH Malaysia, co-organized by Institute of Medical Research Malaysia and DNDi. On behalf of Ministry of Health Malaysia, I would like to express my sincere gratitude to Dr. Luis Pizarro, DNDi's Executive Director, my dear friend, Mr. John Michel Bernal, Regional Director, DNDi Southeast Asia Office, the wider DNDi Southeast Asia team, and all of you here today in the room for being a part of this significant event. 20 years ago, DNDi was formed by 7 partners around the world, and our very own IMR representing NOH Malaysia at that time is one of the research institutions forming DNDi to close the gaps on medical research and development of the neglected tropical diseases and neglected patients. As you might already know, Malaysia has successfully registered Ravidaswe, the very first treatment for hepatitis C, to be developed through South-South collaboration in the country in June 2021. The Ministry of Health Malaysia, DNDi, and other partners. This collaboration started back in 2016 and has helped us improve access to affordable hepatitis C treatment. In 2022, Clinical Research Malaysia, CRM, and DNDi signed a Memorandum of Understanding for dengue research, which aims to help in the development of safe, effective, and affordable treatment for dengue fever. Malaysia is also one of the endemic country partners for the Dengue Alliance together with India, Brazil, and Thailand, who works together with the DNDi to address issues surrounding dengue. As we strive to secure a better future for neglected patients, we sincerely appreciate DNDi's support and hope that DNDi will continue to support Ministry of Health Malaysia by addressing the neglect among out-of-reach communities in the years to come. Dr. Lewis, who is a medical doctor and global health leader, has led DNDi since November 2022. He also served as founder and member of Global Health 2030 think tank, as scientific advisor for global health at Scientific Pearl Paris, and as board member of SIDActions. Having led medical projects for several years in West Africa, he also the first CEO of SALTIS, an international health and solidarity organizations from 2007 to 2019. Now, before we listen to Dr. Lewis, I would like to call upon Dr. Jean-Michel to say a few words about the DNDi Malaysia's collaboration journey, and also to introduce our honorable speaker for the day, Dr. Luis Pizarro. Dr. Jean-Michel, please.
Good morning, everyone. So it is remarkable that, I think very early on, Malaysia, the Ministry of Health of Malaysia saw the opportunity of working with an organization like DNDi, and indeed was a founding member of DNDi. In fact, a lot of the projects we started on malaria were started first in Malaysia. So the history that DNDi has with Malaysia is from really the beginning and the origin of DNDi. I think we went a little bit dormant for a while because as we moved away from malaria, most of the diseases we were looking at really were not in Southeast Asia. And as mentioned before, in 2016, we came back with this project on HCV. We talk a lot about our project on HCV because, in fact, at DNDi, we are very proud of it and very proud of what we have achieved, and also very inspired by what we have achieved. And the inspiration comes from the fact that we see three levels of impact in terms of what we have achieved on HCV. So the first level is, of course, the demonstration that the self-Ravidasvir is a safe and effective treatment. Ravidasvir is a new chemical entity, and I don't need to tell you that, of course, as a medical research organization, to find a new chemical entity it's the purpose of what we are here for. So, of course, we're very proud of that. But I think the second level is also the way we have done it, as already mentioned by Datuk. So the South-South collaboration, the fact that it was done with Thailand, Malaysia, Egypt, DNDi, FINE, MSF, it's a very unusual collaboration. Usually when we think about, especially with that level of efficacy, 97% treatment rate, when we think of new chemical entity, we associate them with a big, powerful and rich company. So there was a demonstration here that we could deliver at an affordable treatment through a different kind of collaboration. So that's the second level, the South-South collaboration. The third level is how, on the back of R&D work, Malaysia developed an access strategy for affordable DAAs. Again, when we think about access strategy, we often think about people demonstrating, advocating, asking for lower price. We engaged that conversation with Malaysia, more than Thailand actually, but very strongly with Malaysia through the R&D angle. So giving the confidence to our partners that we would be able to deliver a combination, that would be a competition, that would create competition in a DAA market and would allow to bring price down. And I think the Ministry of Health understood this and had this very aggressive strategy of access, which means that today Malaysia has access to three DAAs, three combinations, soft-daclitazvir, soft-velpadasvir, and soft-ravidasvir, at the cheapest price in the whole of Southeast Asia. So those three levels are really remarkable. And they are the inspiration to for the work we are now setting up together on dengue. We wanted at the DNDi to capitalize on the ownership that the Ministry of Health of Malaysia took of the HCV program, because we realized that there was a very powerful collaboration, that to have a country lead, as Malaysia did, the development of a new treatment, it was giving it, you know, a dimension. It was creating a partnership between us, Thailand, Malaysia. It was extremely powerful, and we wanted to replicate that around dengue. And this is why the concept of the Dengue Alliance was really to put some of the endemic countries, and that will be the theme that Luis will try to develop in this presentation, to put endemic country really in charge of finding their own solutions, rather than depending on external players. So this is why we were very happy to be here today, to talk about the DNDi, to talk about our work, because we feel that where we are today in DNDi, in our reflection in DNDi, how to tackle some of the global health issue, global access issues, was very inspired by the work we did in Malaysia. So thank you very much. I think I'll leave it to you to, okay. Thank you.
Thank you, Jean, for the very informative speech on DNDi. I'm sure we are all eager to listen to our guest speakers talk today. Before that, we have a video presentation entitled Waiting for the Cure. And here is the visual.
Malaysia, we have more than 400,000 people suffering from hepatitis C. It is a major public health concern.
然后就经过医生的讲解给我听了，然后他说这个肝炎病是很严重的，它会肝硬化，然后就变成cancer就死了的这样子。然后有一个小愿望啦，就是说看这里啊能不能变成做那个民宿啊。可以来这边休息，然后有自己的菜罢了，就可以自己炒自己煮。但是不知道这个愿望能成功吗啦？
Hepatitis C is basically a virus. Primarily, it will affect your liver.
It's sometimes called the silent disease because people with the disease don't know they've had the infection. And it's only many years later that some of them develop cirrhosis, liver cirrhosis, or liver cancer.
然后我就问他说：“这样有没有药可以医治？”医生就讲有咯。然后第一批药，医生给我是和打针的啦，药源吃跟打针的。
The treatment in the past is so, well, I would say horrible to a certain extent and perhaps toxic because we were dealing with the treatment like interferon before and ribavirin.
And the treatment was also for a very long duration and the cure rate was also very low.
没有吃了这个药啊，5个月，医生在 test 啦，抽血 test 了，说我对我这个身体没有效果啊，他说我的 virus 还有存在啦，在我体内，只是医生跟我讲说，就是等新的药进来罢了啦，外国的新药进来马来西亚，然后就等，一等就是等超过已经10年了。
There's actually a revolution treatment in hepatitis C, the DAA.
When the DAA came in, that was sometimes in 2015, I think, into Malaysia. And it's a major breakthrough.
But the issue is the cost. It's very expensive. And not many people can have access to the treatment.
DNDi, or Drugs for Neglected Disease Initiatives, is a non-profit organization and it works to get treatment for neglected population. When DNDi was studying the DAA landscape, they came across remdesivir. And we also found out that an Egyptian company, pharmaceutical company, Farco, had done a clinical trial using remdesivir, and the results were very promising. Following this, DNDi, together with the Ministry of Health in Malaysia and the Ministry of Public Health in Thailand, conducted a clinical trial on the safety and efficacy of remdesivir. We had a 97% efficacy, which made it comparable to the other DAAs. And these are better tolerated by the patient, it has fewer side effects, and it had a better cure rate. A project of this magnitude and complexity requires a number of partners.
So together with agencies and other societies, you can make the impossible possible.
For all of us who have been involved, we're extremely excited that now there is a treatment option, an affordable treatment option for people with infection.
Now we can tell the patient now, I have the treatment for you right now because you all have been waiting. We also been waiting, but now we have the treatment for you. Almost 100% of those patients who've been treated on this clinical trial clear the virus.
Well, the targets of WHO is to end hepatitis C in 2030. The question is how to achieve that goal.
Our part now is that we should try as much as possible to get as many people as possible to be screened, and those who are tested positive should be accessed for treatment.
开始吃第2批新药的时候啊，吃3个月，但是好消息来说我的肝病好了，我的肝炎啊已经降到0了，没有了。然后我就也有 很开心啦，知道说我的病这个疾病啊，肝炎病已经好了嘛。然后他们的妈妈也跟他们说他 OK 了他。
When I reflect back, it could be like a magical journey to me. No doubt that we have challenges, we have lots of problem issues along the way. This is worth an effort. This is so fulfilling and gratifying. We were going to walk through this journey together until the finishing line.
Ladies and gentlemen, without further delay, I would like to introduce our guest speaker for today. Dr. Luis Pizarro is a trained medical doctor at the University of Paris. He holds a master's degree in political sciences and an executive health MBA from a joint program of EHESP School of Public Health, the London School of Economics, and the ESCP European Management School. Dr. Luis has led the Drugs for Neglected Diseases Initiative, DNDi, since September 2022, taking over the battle from Dr. Bernard Pico, who was the founder of DNDi 20 years ago. His responsibilities include setting strategic vision and goals, overseeing R&D programs, and representing the organization to the external stakeholders. So let's put our hands together to welcome Dr. Luis Pizarro to deliver his speech.
You can hear me well? No, it works well. Wonderful. No, but I think it's okay. So let me say hello, maybe in Malaysian. Salamat pagi. Good morning, everyone. I'm very, very pleased, very, very honored to be here. First of all, of course, with Datuk Dr. Ratzi. You are also a cinema star. So thank you very much for welcoming me in Malaysia and of course here this morning. But also to Dr. Tahir, thank you very much for being in NIH and especially with you in IMR. It's a very, very important moment, I think, for DNDi in this 20th anniversary. So with the movie, you have probably seen most of the important messages I wanted to deliver today. So I will try to be short with you, but insisting on some specific points I think are very, very interesting to look now on the future. Because here you see what we are able to do together, but there are so much to do also in the future. And you said, Dr. Ratzi, that DNDi has been supporting some countries, but I would say that in the world we are today, we support each other, you know, all around the world. So it's not about people in Europe or in the US supporting people in South America or Asia. I think the way global health is moving today is how we're going to support each other all around the world. And this is the message, of course, I would like to give. So if we start... No. Can we move to the next slide, please? Or maybe I can use the... yes, the next one. So why DNDi? Why 20 years ago different actors from South America, Brazil especially, from Africa with Cameroon, Kenya, India, ICMR, here, of course, the Ministry of Health in Malaysia, but also the Pasteur Institute in Paris, MSF, and the World Health Organization decided to create DNDi. It's because the situation for access to medicine, and especially for neglected diseases, was this one. You see that the global disease burden of neglected diseases at the time was around 12–15% of all the diseases in the world, but only 1% of the new drugs were targeting those diseases. This is what we call the fatal imbalance that still remain today. So it means that not enough research and development was done for those diseases. As I said before, the next one, please. Different countries, different institutions all around the world decided to come together in order to address this problem, this fatal imbalance. And I insist here because I think it's very, very important to see that DNDi is probably the only international organization working in global health since 2000 that has been created in those different continents by different institutions. And today it's still, you know, this way of thinking, you know, taking all around the world what is the best in science that we are trying to push for. It's not, again, a North organization with people in Geneva, New York, that think that this is what others must do, but it's a way of working together, sharing scientific experience, sharing scientific knowledge, and trying to find solutions together. So this is the origin of DNDi, and it's still our way of thinking today. Next, please. Probably you know that very well, but I thought it was important to insist on what does it mean, this word of neglected diseases, okay? So as you see here, why those diseases are neglected. First reason is because the way we do R&D in most of the countries is the pharma companies who are for-profit companies that decide to start developing, for instance, a cancer drug in order to make big profits with this cancer drug. So if you are a person living in a very remote area without resources, financial resources, and you are affected by diseases that are specific in this region, well, a pharma company will not be very motivated to develop a drug for you because you will not pay for it. You will not have the resources to afford the drug. And we will let you with diseases like sleep and sickness in Africa, Chagas in Latin America, leishmaniasis, for instance, in India, that were completely neglected by the pharma sector. This is one. But it's not only by the pharma companies, it's also sometimes by countries. I mean, I come from Chile in South America. In the north of Chile, we have a disease called Chagas. You have a bug, the keys bug. It's sort of insect you find in very poor, remote houses that it's transmitting this parasite disease. Well, I remember when I started doing my medical studies, I asked my parents, I said, but it seems there is this disease going on in our city, in our region, in the north of Chile. Why you never talked about this? And they said, no, this is because it's the poorest people of this region are just affected by this. So it was okay for you. And I was okay, but if we are neglecting in our region, in our countries, those patients, how we're going to ask international pharma companies to do research and development there. So of course it's diseases, there are diseases neglected by this R&D model, but they are also diseases neglected by ourselves, by our governments, and by our societies. So it's a double neglected aspect. And you can ask me, well, but why hepatitis C? It's part of your job. Because for hepatitis C, as we saw in the movie, we had drugs at the time. Those direct active action drugs were, of course, an amazing outthrough from research on hepatitis C. So they are not really neglected by the pharma companies. And it's true. Hepatitis C is not a neglected disease. But what is behind hepatitis C is patients, and it's because those patients were neglected, by drugs that were very, very expensive, is that we decided also at DNDi to invest with the Malaysian Ministry of Health and other countries in South America to work on this. So from neglected diseases, I think we're more and more moving to neglected patients, and it's all together what we're trying to do. Next slide, please. So the three main, I would say, activities of DNDi will be the one you see here. Of course, research and development. The idea is to innovate, to find new drugs to save lives. The second one is to foster inclusive and sustainable solutions, because the idea is not just to bring a drug, but it's also to see with the health system, and I was discussing here in NIH, you hopefully have not only ICR, IMR, but you have also research in public health, in health system, in health management, and it's very important we think about that to have a whole health system addressing those diseases. And the third one is if we want to develop an alternative model on research and development, we need to have policies at WHO level, at regional level, at country level that are enhancing access to neglected diseases. So those are the three main activities we have at DNDi. Next one, please. So it's not a surprise for you to do research and development. We need to think about all the different stages of the R&D pipeline, going from discovery through translation, clinical development, and implementation. And the way we will work at DNDi as an international organization is trying to bring together, in order to do that, different actors, starting, of course, with patients and communities, because they are in the core of the activity of DNDi, health ministries, as I said before, academia, the pharma sector, and treatment providers. So it's really about putting all those stakeholders together through the whole R&D pipeline. Next one, please. I wanted to insist also about these regional aspects. 20 years ago, we had, of course, national ministries of health working, as it is the case, of course, here in Malaysia. And we had WHO at the international level playing a sort of international multilateral governance. But you have seen probably during the COVID crisis that now we're looking for regional solutions. So in Africa, you have the African Union, the African CDC, the African Medicine Agency, and there is a real, very strong dynamic going on this way. In South America, it's exactly the same. People around PAHO, who is the Pan American Health Organization, are working to find regional solutions. And in Asia, with ASEAN and other regional organizations, people is also looking for those regional collaboration. And at DNDi, we have been supporting in some diseases like Chagas, you see here in Latin America, leishmaniasis, very important in Africa. We have worked a lot, and also in Latin America, with Hepatitis, the human African trypanosomiasis, so the sleeping sickness, very important platform here in Central Africa. And now, as Jean-Michel mentioned before, the Dengue Alliance that will be between India, Malaysia, Thailand, Brazil, and we hope very soon an African country too. So trying to support those platforms in regions, it's also a very important objective for DNDi. Next, please. The result of all of that after 20 years is the 12 treatments you can see here. And you know, I can talk for an hour explaining what we do. At the end of the journey, there is nothing coming in the pipeline. It's just words. So probably why we are really very, very proud of the journey we have done with you and all the rest of the partners is because at the end we have delivered 12 treatments. You see here, some of them at the beginning were on malaria, as AZAC ISMQ. Some others I said about sleeping sickness, about leishmaniasis, about Chagas, and of course here you see the Ravidasvir that was presented in the film, a very, very important one. So 12 treatments after 20 years. I think DNDi is the only international organization in 20 years working with all the partners that have delivered so many drugs in such a short time. Next one, please. But it's not only about drugs. As I said before, there is here how to foster clinical research, knowledge, and collaboration. So you see also how many clinical trials have been conducted, the number of partnerships that have been created all around the world, how many policies in countries, in regions, and even at the World Health Organization have been influenced. You see, of course, the pipeline with new chemical entities coming, the networks, the trainings, and even a new organization was created 5 years ago called GARD-P, working on antimicrobial resistance, AMR, that it's a sort of spin-off coming from DNDi. So a lot of different successes in 20 years. Next one, please. You have received, coming here, this brochure trying to summarize what has been done also in the collaboration at the Malaysian level. So you will find most of the data you have in this slide in this document. And we tried, of course, to highlight here not only this important milestone that is the Ravidasvir, and I think everybody here is very, very proud about the work that has been done. But as you see in the numbers, how many clinical trial sites, participants have been included here, it's really amazing. I mean, you probably, it seems maybe normal for you, or you are not surprised because the number of research projects you have in Malaysia is very huge. But for somebody like me, as I said before, coming from South America, have been working a lot in Africa, I can say that there are very few countries that has done so much as Malaysia has done during this time. So really, really huge numbers here and achievements to be proud of. So really big congrats to all of you. And I insist what was done on the price of hepatitis C drugs, when you see you went from 300,000 RM to 500 So a reduction of 99% of the price of hepatitis C drug. Wow, this is really a very, very important achievement. Really. No, this is for you. You can really be proud of that. Next one, please. So I said the important, it's also to talk about the future. And I wanted to insist here maybe on 3 specific points. So we have a strategic plan going to 2028. Of course, we have delivered 12 drugs, as I said before, but the idea is to bring additional 5 to 7 new treatments. So we're working very hard on that. And I would like to insist, please, the next one, I said on 3 maybe transversal topics. The first one, please, next slide. The first one, and yesterday we had a meeting with 8 very, very powerful women here in Malaysia. I was really impressed. Is how we can make this R&D sector, this R&D, response, being really critical on gender. What does it mean? Of course, it's to have a good balance between men and women doing research. Research has not to be just the monopoly of men. We need to open doors for women in science. I realized yesterday that here in Malaysia, it's already the case. And when I see the assistants, I also congratulate you because you are giving a chance for women here to be part of the research you're doing. So that's fantastic. But I can assure you that it's not like this in many parts of the world. Okay, so for us in Latin America, in Africa, in other countries, we need still to insist a lot about that because most of the science is done by men and we need to look for a better balance. It's of course also on how we publish articles, because sometimes you say, okay, yes, we're well balanced on men and women, but it's always the men, the first author or the last author, and who take the credit. And of course, that's not fair. So we need to be careful about this. Fine, that's good. And I thought that was all. And I realized coming here, working at DNDi, that there is also something very, very important, is that the new drugs we are developing are really thought with the woman needs. If you live in Sahel, in the countries like Niger, Mali, Burkina Faso, and you don't have access to contraception, if the new drug you're giving you for a disease has teratogen effects, it means that those drugs will have effects in the baby you have during the pregnancy. Well, you cannot take this drug. So do we want to develop a new drug that keep 40% of the population outside of the treatment? No, we cannot. So we have also a duty. We have really to think about those drugs we are bringing, to the market, to the health facilities, having in mind what are the women needs. And this is also the way we need to do a gender responsive R&D. So again, I think a lot of countries in the world have a lot to learn from the Malaysian experience. And yesterday, we had this event on Women in Science. We will try to push for that here to give and to spread the message from women to the rest of the world. Next slide, please. This is not a surprise for you. We have a lot of crises going on, an economical one. We have a war, for instance, in Ukraine. We have conflicts all around the world, but it's a big, big crisis behind that. It's the climate change crisis. And it's going to change the way we work, the way diseases spread in a dramatic way. Example, dengue. And we're going to work together on dengue. Last year, an outbreak of dengue arrived to the south of Europe. European countries realized that dengue was a reality. Yesterday, in Argentina, Argentina is really the south of South America, more than 20 deaths and more than 20,000 dengue cases were reported in Argentina. I mean, it's a place where nobody thought dengue will arrive there. And this is because the climate change. So we need to take that into account. We need to see how the health system will respond to this climate crisis. I would be very, very happy to discuss with you and to engage on that. And the third one, please. Next slide. Yeah. And the third is the revolution. New technologies, and especially artificial intelligence, are bringing to the way we work. You have heard probably about ChatGPT, for instance. I don't know if you're using ChatGPT. As a professor, we are thinking now when our students will send the exams, is ChatGPT or my students sending the exam? So you probably will experience that. I said to Jean-Michel coming here that my assistant did some letters 2 weeks ago, and she was very embarrassed because she didn't want to tell me that she used ChatGPT. And I said, well, it's fine. I mean, if you are saving time during using ChatGPT, okay, fine. So, okay, those are curiosities, and it will probably enhance the way we work. But for research, you know, the way it's going to speed up the capacity to discover, to modelize proteins in the cell, to screen different drugs, to see if they are potential candidates for these or these disease, this is completely an amazing change for all of you. What are going to be the outcomes? We don't know already. Are we going to need to change the way we work, our professions? I really don't know. But I know that this is coming very, very fast, and we need to integrate that, and we need to work together to use it in the best way, and for us, for the most neglected. Next slide, please. So this is the pipeline of DNDi collaborations today. Sorry, because it's probably a little bit small. You have here at left the different diseases we're working on. So sleep and sickness, leishmaniasis, Chagas, filariasis, river blindness, onchocerciasis, mycetoma, a very, very neglected disease. Probably you have never heard about mycetoma. Those are fungus or bacteria you get in the skin when you work on your pieds nus, barefoot, you know, without shoes. And then you can have big, big infections that if you have no treatment, go to the amputation. I mean, you really have to cut the leg if it's not treated. So those diseases are mostly around Sudan, Ethiopia, and we're working on, because no drug existed for that. Dengue, HIV, hepatitis C, and we worked a lot on COVID during the crisis. So why I think it's interesting to show that, because you see that for some of those diseases, we have candidates here at the left, at the hit to lead or the lead optimization side, and that's good. But you see that most of the drugs we are working on are going to the end of the pipeline. So that means that we will need to start thinking on how those drugs will be delivered to the patients. Because it's good to have a new drug, but if the drug is not arriving to the patient, why did you do your work? So, and that's why I said here at NIH, I think you are very well equipped to work on that, because you work on public health, you work on health system, you work on health management, and it's doing this implementation science that we will succeed to bring this drug to the patient in the health facilities. Next slide, please. I will not be very long on hepatitis C. I think the movie really summarized all the work that has been done. So the drugs are there, prices have been reduced. Now it's our duty to eliminate this disease from all the countries that have the possibility to do it. And we are, again, very, very proud to be with you on this fight. And the next slide, please, is on dengue. As I said before, this is an alliance, what people call South-South alliance between Asia, Africa, and Latin American scientists. It's something that it's acute now with the global warming, with the climate crisis, we need to work on. We're going to develop new drugs with partners in India, in Brazil, working with you here in Malaysia. And we're going also to try to repurpose drugs that already exist, antivirals that have been developed already. So using a double approach, repurposing drugs we have now and looking for new antiviral we want to mix with what we call host-directed therapies. Because most of the drugs in the past were chemical entities, and you know very well here that with the development on immunology, now with monoclonal antibodies, with biologics, with all those new possibilities we have with research, we need to mix and we need to do combinations in order to cure dengue. And dengue, and again, I insist because you're interested here in public health and in health system, it's not only about people who die from dengue, it's also your health system that is having a big, big burden with hospitalization, you know, with hospitalization sometimes in intensive care unit, with the drugs you need to do there, etc. So, of course, we are interested in patients, but we are also interested, I would say, to alleviate the health system. Next slide, please. I would like to finish with a comment on access. As I said before, once you have the drug, you need to think about how to bring this drug to the patients. And it's very, very important, of course, to think about production and supply. Sometimes it happens for neglected diseases that you have not huge volumes. So not all the pharma companies are interested in this. And we need to engage with generics to say, okay, we will try with you, with international organizations, with countries, to do a partnership to manufacture those drugs and make them available in the health facilities where patients are. So very important, the partnerships for production and supply. As we have seen for hepatitis C, how we can improve market dynamics, and the fact that with Remdesivir here in Malaysia, you shaped the market, you challenged the pharma companies, immediately the price dropped down. We need to think all the time, you know, how to support those dynamics. And the last one, as I said, is not a disease program. It has to be a primary health program. So how you integrate, for instance, the sleep and sickness approach into primary health care in remote areas. Here, it's exactly the same. You cannot afford to have a program on hepatitis C, on HIV, on TB, on malaria. At the end, when you are in remote areas, you have just one doctor. And this doctor, this nurse, has to work with all the diseases together. So how we integrate those diseases into primary health care, it's a very, very important issue. Next slide, please. My main message to conclude will be everything needs to start at the patient level. We like to say at DNDi that we are a patient-centered organization, and everything we do, and I hope you are doing too, start with what are the patient needs, okay? We're not doing this just because we are scientists, we are excited about research, and we want to publish an article, etc. We're doing this because we are conscious that those patients are suffering from those diseases and are really why we have been trained as doctors, as researchers, nurses, etc., is to come here and address the patient's needs. So all these drugs need to respond, to what are the population needs, the clinical efficacy, the safety, the stability, the route of administration. Sometimes we find drugs intravenous. How are you going to bring an intravenous drug to the east of Congo when you have to take the boat, when there is no fridge? Here you have, this luxury place with everything you need. But those patients, they live in places with 35 degrees, 90% of humidity, no fridge. If the drug is not heat stable, if the drug is not a tablet you take orally, nobody will take it. So we need to think about all of that and of course about price in order to respond to these needs. So this is really a very, very important message I wanted to share with you. The patients always in the core of our mission. And just to conclude, my last one was a little bit what we have learned on COVID. Next one, please. What are the COVID lessons, I would say? Because, of course, those last 3 years, all of us have been impacted and we have been working on COVID. And for me, it was a surprise because NTDs, neglected tropical diseases, were there for a long time. And I thought, okay, in a pandemic situation, things are going to be different. But at the end, we see that it's exactly the same issue about access. Look who had access to vaccine for COVID, to diagnostic tools. The same people, the same countries, the same populations that are having access today to cancer drugs or to all the diseases that interest the pharma sector. And people living in remote areas, in poor regions, they didn't have access to vaccines. So the same causes, the same roots of neglected diseases were also at the origin of this COVID, I would say, separation. So we need to work since the beginning. It's not acceptable that Europe, the US, gave public money, millions, sometimes billions, to pharma companies. And once the vaccine were there, the drugs were there, the governments were not able to say, look, we need to send those vaccines here. We need to treat those poor patients there. There is something in the research and development model that it's really going wrong. And it was very, very clear too with this COVID situation that showed those differences. So if we can learn from that, if we can now change conditions when governments are giving public money for research to be sure that everybody will have access in an equitable way at the end, I think that that will be the best lesson we can have from COVID. So thank you very much for your attention and very happy to respond to any question you have.
Thank you, Dr. Luis, for the very informative presentation. We now open the session for questions and answers. The microphones are at both sides of the aisle, so please feel free to ask any questions you may have.
And don't be shy, please. You have seen I'm very open to engage in any topic, so please.
Hi, thank you for a very inspiring, I would say, and thank you, DNDi, for taking up the neglected disease. My question would be, How do you prioritize which disease that you study? Because that's a whole lot, I can imagine. So how do you prioritize?
Thank you. Thank you very much. Of course, it's a very important question. First of all, it will be never DNDi alone doing this. As you have seen, we are an enabler organization. So it means we put together people who are concerned by a disease. For instance, in dengue, we try to gather colleagues from countries that were affected, and we discussed everybody at the same level around the table what we want to do. Is it necessary to go there or not? So let's say it's a collective decision. But there are probably two ways of doing this. One can be a very opportunistic option. For instance, we received from a company working on a drug for snake bite. You know, you probably see that in Asia, but it's the case in Africa, it's the case in Latin America. When you are bitten by a snake, you need to run to a health facility to receive the serum. But when you live in a very remote area, and sometimes you have one day to go to the health facility, you will die going there. And a company from San Francisco in the US said, we have a very specific drug that will allow people not to be killed by this in 48 hours. So you have time facility for the serum. And we discussed with colleagues, you know, in different parts of the world, and we said, okay, there is an opportunity here. Let's take it. So let's go on snake bite. So this is, I would say, more the opportunistic way. We need to take the opportunity. There is a second one that it's a more long-term vision. There is another parasite called schistosomiasis, or some people call bilharziosis. You have in the rivers around, etc. We use now one drug in a mass drug administration mode, okay? And consequentel. And this drug is now developing resistance. And we know that in the next year, we will not have a good drug to cure from this disease. So we started talking to the pharma sector, to some research, etc. And we decided that we needed to do something here because the burden of this disease is very high. So we are launching now a long-term program on schistosomiasis, you know, of course, with WHO in Geneva, research companies, but also some pharma sector. So I would say a double vision for that.
Any more questions? Hi, thank you for the inspiring talk. And there's another group of patients, probably it's not really neglected, but the rare diseases, the diseases of the, for example, certain of inborn error of metabolism, of inborn error of immunity, for example. So this group of patients, their treatment is very expensive also. But because it's genetic disease, perhaps, there's limited things that you can do. So are you all into this as well?
Yes, absolutely. Well, first of all, as you can imagine, we have already a lot of work on what we have. For those, so we cannot address everything, but I think we can learn from each other and from each situation. So rare diseases, the big difference will be that the volume is very low. In those neglected diseases we're talking here, there is a list of WHO, around 20 neglected diseases. They cover 1.5 billion persons in the world. So that's why we call them neglected, but not rare, because they are quite frequent. 1 billion people in the world. We're talking about 20% of the population in the world. That's why we're here. Nevertheless, in the rare diseases, you have the same R&D model issue. It means that if you are not a for-profit disease, the pharma sector will not take care of you. And this is why I think it's so important that our governments, our regional institutions, put their finger here. And that's why I think also you can be very proud in Malaysia, because if things worked here for hepatitis C, it's because you had a political commitment that didn't happen in other countries. I mean, your Ministry of Health, NIH, IMR, everybody, people took their responsibilities and they said, I mean, this is our population, those are our citizens, and we cannot let them like this. And they engage funds for that, And for the rare diseases, I think it should be the same. We cannot let the pharma for-profit R&D model going on like this without any control. So sometimes some countries like Brazil, for instance, or here with your own generic company, countries can decide to produce themselves, okay, as a public company. In other countries, they said, no, we don't want to go there, but we're going to ask the pharma company to develop a drug for this. It could happen too. And we researchers, academics, we need also to support that. But I would say the similar approach is on the way our governments and us scientists, we decide to take care about our citizens, about our communities.
We have also received a couple of questions from online viewers. So first one from Alan Tay. He expressed his appreciation for all the uncountable and continuous effort in finding disease cure. And the question is, with the current scientific evidence, how close are we to cure dengue?
Far. Very far. No, because we don't have a drug for dengue already. So again, what I would like to say and repeat is that it's important to have a double approach to look for the drug on dengue. So the same we did for sleeping sickness. It's starting by antivirals that already exist. So you don't need to go the preclinical research or the phase 1 because they have been already tested, but you go immediately to phase 2 and 3 with those repurposing drugs, okay? So this is the way we hope in 3 or 4 years we can bring, a treatment for dengue. But parallel to this, it's also very important to explore new antivirals, new biologics, so really new drugs from the beginning in order, in a longer period, it's going to take most of the time for a new drug, around 8 to 10 years, to have the right solution at the end. So let's say the R&D pipeline will be between 4 and 5 to 10 years to have those drugs.
Right, thank you. So perhaps last question we have from IHM. Do you mind sharing your experience on how people with neglected disease and in a neglected population accept the new treatment provided to them?
Yes, I mean, of course, when you start after a clinical trial to distribute drugs, there is the people call that sometimes post-marketing phase or the phase 4 with pharmacovigilance, that it's absolutely key, to follow up. And this is something also we do in collaboration with all the national partners where drugs are distributed, for sure. But I would like to insist again on the very important collaboration between your research organizations here at NIH, one side, ICR, for instance, or IMR, doing the first part, the clinical, the biological research, with your colleagues doing public health and health system research. Because it is about, once you have the drug, when you have, for instance, a test and treat model of care, is assessing how this model of care is well integrated into the health system. If patients are not receiving the drug, are not being tested for the disease, all the work you have done was for nothing. So trying to put together, as you are doing here in the NIH, you know, the health system research with the clinical research, I think it's absolutely key to address this point.
Thank you. We have one more question on the floor.
I'm just going to ask, because like what you've put out with your success story, what is the failure rate? The one that you didn't, the one that, because we know research is always not about the success, there is always about the failures, but the trying is there. But how much was there? And if it's all, it's all good news, what is your secret?
No, of course there are. Well, first of all, I can use my joker, let's say, saying that I arrived to DNDi just 6 months ago. So I have not been working with DNDi for 20 years. I'm less familiar, I would say, with the whole story. So excuse me if my response is not very acute. But I'm looking at Jean-Michel saying, Jean-Michel, please help me on this one. No, but yeah, of course, Jean-Michel, I will let you maybe share your experience here in Southeast Asia on this point. But first of all, there are a lot of failures, not failures, because it's the research, it's like this. To bring a new chemical entity, in the meantime, several of candidates will fail. Okay, and it's already last year, for instance, on leishmaniasis, that unfortunately it's very poor in terms of drugs. We had 3 candidates. We were very enthusiastic that failed for different reasons. Sometimes, you know, as I said before, teratogen effects. So we didn't want to push for a drug that will not be available for women during their fertility age. So that was a failure. Or it can be a drug we see in animals, for instance, that are, you know, bringing too much side effects. So this is the classical R&D failures, and that happened for sure. It can happen also that to do that, you need funds. You need a lot of funds. You know, a pharma company will tell you for one drug, it's about billions. We know we are able to bring a new drug with, let's say, between 100 and 200 million, but that's a lot. So it's not just one country paying for that. It means that international donors need to participate. The pharma companies need also, you know, to make an effort, etc. And if you don't find enough resources, you know, to go there, you will not be able to do that. And of course, in 20 years, we were not always able to find the resources. But please, Jean-Michel, maybe you can be more precise here in the region.
No, I will speak about the cost of failure, because you're right. In the industry, I think it's a big cost for the industry. So they always challenge us when we say we are cheaper in delivering drugs, because they say yes, but it's true that our model, which is a collaborative model, in that model we do benefit from pharma failure. So we don't start from scratch often. So that means we are a bit, even though they are the failure that Luis has described, we are able to reduce that. Usually in pharma, it's a high level of failures, you know. So I think we're a bit lucky there. Because of the model, we don't have such a high level of failure. Therefore, we don't, the costs reduce, and we don't have to carry that financial risks. That's due to the model. It's true the cost of failure will always remain high. And that's an important element of R&D.
Just one question. Excellent talk, Dr. Luis. This basically, I think, lesson learned during COVID. Access to diagnostic kits is one of the problems that many countries face. So I know FINE is one of your partners for diagnostic tools. Is there anything like similar to that, like Dengue Alliance partner, South-South or North-South Alliance, we're developing R&D for diagnostic kits? Thank you.
Yeah, for those of you who are not familiar, we have, since 2000, some new actors coming in the global health landscape. Some of them have been funding, health programs like the Global Fund, very well, on HIV, TB, malaria. Another one, Gavi, on vaccines. Those are very good. And you have new actors working to develop drugs like DNDi, but also to develop diagnostic like FIND, F-I-N-D, a very interesting organization based there. So we have been working with FIND to have those model of care, I said before, test and treat. For hepatitis C, it has been very important, and you have here in the brochure, the HEAD program that was developed is the one you have at the left, supporting implementation of Head Start study on retention, HCV care cascade for people living with HCV in Malaysia. This one was done with FIND, so hepatitis C test and then treatment. So that has been very, very important. But for dengue, Jean-Michel?
So we are one of the things we're trying to do around HCV is to bring it a little bit further to use the experience of Malaysia, but also of Egypt, because Egypt has also been a leading country in HCV elimination. And we are discussing with the Islamic Development Bank and the government of Malaysia whether we can carry this experience and have an elimination strategy for countries that are member of the Organization of Islamic Countries. In that initiative, there is a screening component, obviously. It's access to DAAs, but also we need to have, as you rightly said, screening. And the group we are discussing with in Malaysia is proposing that Malaysia takes the lead on the screening component with an organization which is called Mologic. They have a new name, which is GADEX. It's a British-based organization, but very much the same philosophy as DNDi in terms of working partnership and ensuring that the knowledge and the technology is developed in endemic countries. So that could be a very interesting initiative for Malaysia with Malaysia leadership, and this could be extended to dengue because they are very interested to go beyond. Of course, if it's diagnostic, they don't need to stay on HCV, but they're interested to see if Malaysia could become actually a hub for diagnostic dengue, malaria, HCV. So that's the initiative we have at the moment. Whether it will deliver or not, it depends from your Prime Minister.
Thank you very much, Dr. Luis, for the very informative interactive session. We are certainly privileged to have Dr. Luis with us today. Let's once again give a big round of applause to Dr. Luis. We also have a small token of appreciation for Dr. Luis, and I would like to call upon Datuk Radzi to be on stage to present the token. Thank you, Dr. Razi. Dear all, we have now come to the end of the event. I thank all of you for your presence here today. Also, please remain at your seats for a moment for photography session. Thank you. I would like to request all to come forward.